Hello, everyone. My name is Jordan Bird. I am a student registered nurse anesthetist. I am currently completing my doctorate of nurse anesthesia practice at Keiser University in Naples, Florida, and I am set to graduate in August of 2026. And today I'll be presenting my capstone project, which focuses on evaluating the role of peripheral nerve stimulation in modern regional anesthesia practice. And this topic is quite important because it is reviewing one of the most used tools and techniques within the history of regional anesthesia. And to start off, I will begin by explaining the purpose of my capstone project, and then I will walk through the background of regional anesthesia and how it has changed over time. And then we will also look at current evidence and clinical implications for this topic and ultimately discuss how it applies to today's practice and the future of regional anesthesia. Alrighty, so moving on towards the purpose of my capstone project, I first wanted to touch on a few definitions just to make things a little bit easier to understand before we proceed. So I wanted to first start off by defining what regional anesthesia is. And there's a few different types of anesthesia actually. One of the main ones is called general anesthesia, which is a big term that basically means your whole body is going to sleep. Like when you inhale some anesthesia gases, basically your whole body becomes anesthetized to where you could operate on any part of the body and you wouldn't be able to feel it as the patient. But regional anesthesia is very unique in that you're only anesthetizing a certain region of the body. And you might ask, why would we want to do this instead of general anesthesia? And this is a great option because for many patients that have an extensive health history or higher risks of going under general anesthesia, regional anesthesia avoids a lot of the complications and risks where when your whole body goes to sleep, you have a lot of other things you need to worry about, like keeping your patient breathing throughout the procedure. So regional anesthesia is a great option, and there's many ways that we can go about delivering anesthesia through regional anesthesia. And we use something called a local anesthetic, which is a name for medicine that blocks nerve impulses when you inject it around the body. Just like when you go to the dentist, it numbs up your gums so that they can work on your teeth and you don't feel all the pain from it. So one of the techniques or tools that has been widely used in the past is called a peripheral nerve stimulator, which basically sends an electrical impulse through the needle that is used during the regional block, which can tell you how close you are to a nerve. So as those impulses are being sent and your needle is really close to a nerve, it will basically tell you how close you are so you don't get too close to where you can accidentally puncture the nerve and damage it, but close enough to where you can inject the local anesthetic and numb up that area so that it blocks all the impulses. So if you were working on the foot and needed to operate, basically numbing up a nerve in the leg is kind of like a highway of nerves going all the way up to the brain. And if you put a little road stop between the foot and the brain, then your brain won't sense that pain. And that's how regional anesthesia works. So the peripheral nerve stimulator helps us find how close we are to the nerve and to hopefully inject the local anesthetic to help with pain control during the surgery and post-operative pain control as well, and being able to use less opioids. And why I chose this topic is actually a cool scenario where when I started anesthesia school, you had to take a regional anesthesia class, and they teach you about all the different techniques and tools that you use to safely deliver regional anesthesia. One of them is the most important one is called an ultrasound machine, which allows you to see under a patient's skin, looking into their tissues and locating the nerves. And you can actually see your needle and being able to watch the local anesthetic being injected. But one of the other tools that was iterated to us many times was the peripheral nerve stimulator. And when I started clinicals, just like many other students, you see the needles that have the peripheral nerve stimulator wiring on it that allows you to plug it into the electrical device to stimulate the nerve. However, many, if not 99% of anesthesia providers would just rip off that wire or just leave it there and ignore it and simply just use an ultrasound as their sole mode of delivering the anesthetic. However, I was wondering if we are doing a disservice to our patients by not utilizing the tools that the hospital and facilities have already purchased, and that we should be trying to provide the best quality care that is possible to these patients. And I wanted to do a capstone project to assess if the peripheral nerve stimulator should still be used as an adjunct alongside the ultrasound machine, or if it should be used as a backup method if a facility doesn't have enough ultrasound machines, or there's any technical difficulties, or the ultrasound is just not able to see the nerves good enough on a specific patient, or if the peripheral nerve stimulator should not be used anymore with the increasing use of the ultrasound machine, as it is the superior mode of delivering local anesthetic in regional blocks. And now moving on, I just wanted to quickly touch on the background of regional anesthesia and cover the evolution of how it has changed over time. And although there are many milestones or changes over time, I'm just going to touch on the most important changes. But to start off, in 1884 was actually the first time a nerve block was performed using cocaine. And they used a technique where they used landmarks of the patient's anatomy and paresthesias, where the needle that would inject the local anesthesia would be penetrated through the skin and directed towards the nerve that they're trying to find. And as the needle would touch the nerve, they would feel a very uncomfortable or possibly painful sensation, letting the anesthesia provider know that they are likely in a good spot to inject the local anesthesia. However, this was highly dependent on the skill and experience of the operator, as well as the patient could not be sedated, as the anesthesia provider needed them to give them feedback on what they were feeling. But later on, things got a little bit easier in 1912 when the invention of electrical stimulation was introduced, which basically let the electrical stimulation go through the needle and direct it towards the nerve that they're trying to find. And as these little electrical impulses contact the nerve, you can be more sure that you're closer to the nerve and you can inject the local anesthetic. And then later on in 1966 was a big step forward when they created a battery-powered portable nerve stimulators. So this took the same technology as before, where you're sending electrical impulses at the nerves, but it's a portable version, which makes it a lot more practical and useful for regional anesthesia. And this soon after became the gold standard. However, it still had limitations, such as patients had such variability with their anatomy, and even if you've been very experienced with this, a patient's history or differentiating anatomy could completely change things and make it hard to have a successful anesthetic block. However, in 1978 was when the invention of the ultrasound took place, and this allowed for real-time visualization of nerves, vessels, the needle and the needle tip, and even injection of the local anesthetic and watching the spread go where you want it to. This improved accuracy and precision, higher block success rates, fewer complications such as having vascular or nerve puncture, and also reduced the risk of something called local anesthetic systemic toxicity or LAS syndrome, which basically means that when you inject these amounts of local anesthetic in different parts of the body for regional anesthesia, sometimes, unfortunately, it can leak back into your vasculature and go places where you don't want it to, such as the brain or the heart, and it can have high side effects, which we're trying to avoid. So ultrasound helps prevent that. And then as time moved on, the shift in practice continued even more, where ultrasound became the primary method for regional anesthesia because it was easier to pick up for new grads, as well as trainees could learn just by watching the screen of an experienced provider doing a regional anesthesia block using ultrasound. And while the peripheral nerve stimulation was still available, it had a decline over these past decades. And that's where my topic comes into play, where I'm wondering if it is still necessary to use the peripheral nerve stimulator, or if it should not be used anymore. And now moving on to the methodology of my capstone project. The design I chose was a narrative literature review, and it was a desk-based capstone project, which means I had no direct contact with any human subjects. And although this was the case, I still respected any and all personal information for the sources that I found. And I also submitted to the IRB to make sure that I was compliant with all research. And the databases that I used were two different ones known as PubMed and CINAHL. And I used 3 identical search term phrases for each PubMed and then also for CINAHL. And the filters that I used were English, adults, and within the past 5 years, which was from 2020 to 2025. And besides this, I did do an additional spot search for PubMed indexed articles on Google, since I did find some there that were not found on my initial searches directly through PubMed. And with my initial yield, I found 194 studies. And after I started to screen them, looking at the titles and abstract, making sure that they are what I was looking for, I was able to remove those that did not help or had anything to do with my capstone project. And I removed any duplicates that I found. And then I went more in depth to the full text reviews and made sure that they met all the inclusion requirements. And this included that they needed to be concerning ultrasound versus peripheral nerve stimulation or combined, or peripheral nerve blocks or the clinical relevance, but it would be excluded if it was talking about something different, such as chronic pain stimulators, neuromuscular blockade monitoring, pediatric only studies, or non-peer-reviewed sources. And after all of my refinements, I arrived at 15 studies, which included random controlled trials, comparative, observational, and literature review studies. And besides this, I also selected a few sources to introduce my readers into what regional anesthesia is, the benefits of it, and the evolution of regional anesthesia. So from the 15 results that I found for my capstone project, there was a commonality between many of the studies in that they found that ultrasound consistently showed better outcomes compared to nerve stimulation alone. There was one large study that reported block success rates with ultrasound at 91.8% compared to only 82.8% with nerve stimulation alone, along with a significant reduction in vascular puncture. And across other studies, ultrasound also required fewer needle passes and allowed for shorter procedural times. And when nerve stimulation was used alone, it did not provide any clear benefit and was often associated with longer procedural and increased needle manipulation. Some studies looked at combining techniques, which is referred as dual guidance when ultrasound is combined with nerve stimulation. And in certain circumstances, you can also add a third tool, specifically injection pressure monitoring, which this is termed triple monitoring when you use all three tools together. And these approaches support a multimodal approach and commonly demonstrated increased benefits. However, in most routine blocks on healthy patients, adding nerve stimulation did not improve success or efficiency compared to ultrasound alone. However, there were some exceptions in more technically challenging or deeper blocks or patients who had severe obesity or edema. For example, with supraclavicular blocks, a study found combined guidance reached a 100% success rate compared to about 91% with only using ultrasound. And in lumbar plexus blocks, which are usually deeper and more difficult to visualize, combined guidance reduced block failure from 31.8% to only 9.1%. But overall, the results support ultrasound as the primary technique, with nerve stimulation offering selective benefit in more difficult and deeper blocks. So in conclusion, throughout my capstone project, I found that the ultrasound was the best option for almost any regional block, and that the other adjuncts, such as a peripheral nerve stimulator, can be useful while using it alongside the ultrasound. However, it wasn't recommended to be used in all routine cases of healthy patients going under like superficial blocks, but it is good for deeper, more technically challenging blocks or in patients with difficult anatomy. And although it wasn't my original focus at the beginning of this project, as I went through the results of the studies I found, there was no consistent finding that showed that the peripheral nerve stimulator used alone was ever better than the ultrasound alone. So I did not recommend that the peripheral nerve stimulator be used alone if an ultrasound is available, but it can be used as an adjunct or a backup if the ultrasound is not available. And for this reason, it's recommended that healthcare facilities prioritize their resources to obtain ultrasound equipment because it is so beneficial, and it even has other uses beyond regional anesthesia, which makes it a good purchase for them. And looking into the professional organizations such as the AANA, as well as the American Society of Regional Anesthesia and Pain Medicine, they both support ultrasound as the standard of care, but they still allow flexibility using many of the other methods. So to finish, I would definitely recommend future studies be done, especially larger studies, since many of the ones I found were on the smaller side. They should also have standardized evaluation of peripheral nerve stimulation so they can be compared apples to apples. And provider skill retention should also be a focus, since peripheral nerve stimulation is not being utilized as often in clinical practice anymore. And another lacking study was the long-term nerve injury comparison between different techniques of regional anesthesia would be recommended. This was all my capstone project, and I appreciate you listening.